graduate from College of Dentistry at Kafir University, MSc in Department of Aesthetic and Restorative Dentistry, and he will talk about full mouth rehabilitation against the bone. Please.
Assalamu alaikum wa rahmatullah. Thank you, Mr. Chairman. Dear audience, it's a pleasure to present our case, full mouth rehabilitation, a case report. And actually, it's a great opportunity and pleasure to be on the stage in front of my profs, my teachers, and my colleagues. So I'm going to start with the first slide. This case is one of the cases that we work on the postgraduate clinic of conservative department, me with my supervisor, Dr. Manhal Abdulrahman. The patient attending the clinic with 57 years old, complaining from aesthetic and functional problems, and the patient has already placed a dental implant, only the fixture outside the college, inside a private clinic. And we can see this clearly on the drafted photo. He put 8 implants in the posterior and anterior area. So, as always, we have a plan, and our plan was mainly divided into 3 phases. The first one was the diagnostic phase, where we collecting all the data, we make the clinical examination, radiograph, we taking the scans for making a study cast. And the second corrective phase was where we do the periodontal treatment and any restorative treatment. And the final phase, the reconstructive phase, where we do the final preparations and cemented our final restoration. So this is the panoramic view for the patient, the radiographic analysis. We started to take a full set for documentation, a photo. We started by a frontal small photo. We use a mobile dental photography. This is the right smile, left smile, and this is the rest photo. And actually, this is one of the most important pictures in our plan. We can see there is no incisor show at rest regarding the location of the incisor edge of upper central. This is the retracted view, upper and lower occlusion photos. And at maximum tuckus patient, the overbite was 5 millimeter. And the big question now is, does we need to elevate the bite? Does we need to change the occlusal vertical dimension? And why? And the answer is, in this slide, we can see the deep bite. We already say that it was 5 millimeter over wide. Also, there is no incisor show at the posterior area. There is not enough space for the prosthetic part and for the implant. And for the over eruption premolars, if we need to make a positive smile line, we need to cut too much from the tooth structure. So we decided to open the bite. And the first point, the first step, always making digital smile design, 2D smile design, depending on the golden proportion, 78% for the height width ratio for the central. Then we take in centrifugation using leaf gauge, taking a scan, upper, lower, with scan bodies. This slide shows this patient at maximum tuckus patient. After putting just a little amount of leaves, there's just a little light disocclusion, and this is the verification for the digital scan. Taking Facebook record, mounting the upper cast to the analog articulator, then changing to a digital articulator. So at the end of the day, we have a digital articulator, upper scan, lower scan with a bite in centrifugation, elevating the pins digitally. We decided to elevate 1.5 millimeter to give the best aesthetic and functional result. So this is the digital workshop. The lab sent us a cast, a wax-up on teeth, a PMMA on implant, silicone index to convert the digital wax-up into mock-up inside patient mouth. This is the social smile after we put the mock-up, the right side, left side. The digital subtraction was easy to convert inside the patient mouth by the same mock-up. And this is the enhancement of the incisal show at the repose and the rest photo. This is the impact of our mock-up on patient face. So after we checking all the aesthetic requirement, now it's the time for function. I have a little video for this. Up and down, left and right, checking static and dynamic occlusion. Moving to the second phase, the corrective phase, where we're doing the scaling polishing, endodontic treatment, composite restorations. And this video, although it's from the preparation visit, we can see clearly there is a slight mobility. It's like a grade 1 mobility on the lower two central. So we decided to split these teeth by doing a connected crowns. Reaching finally to the third phase, the reconstructive phase, where we're starting with teeth preparation. And we've done the preparation to mock-up. This is already literature by many publishers, by Manhal et al. In 2004 and by Gurul et al. 2012, sorry. This is the final preparations, upper preparations, lower, and I use the same PMMA as a posterior stop to capture the final bite and maintain vertical dimension. This is the final scan. And same mock-up used as a temporary. I use Teflon tape on papilli just to give more hygienic temporizations. This is the PMMA. And our plan was making two veneers, two lithium disilicate, cemented to zirconium core at the left side of upper anterior, just to make more aesthetic results. Also, fabrication of titanium bar for the lower posterior implant. This is the try-in, upper, PMMAs, lower. This is the final evaluation for aesthetic after we're converting to final, the absent as the final restoration. These two veneers with zirconium core, also with fabrication of titanium bar. So it's like a group of homogeneous restorations between lithium disilicate veneer crowns, connected crown, and for the implant part we use titanium bar, hex and non-hex tie bases, depending on the implant parallelism. Time for cementation, and always we have two options, two routes, conventional cementation or adhesive cementation, and we go for adhesive cementation. And this concept mainly depending on making roughness on the substrate and using a chemical material. So it's mainly conditioning like surface 1, surface 2, and a resin cement in between. Okay, I will try my best. For the teeth, we started for the titanium treatment, and for zirconia we followed APC protocol using a dual-cure resin cement. For the EMAX, as you all know, hydrofluoric phosphoric saline coloring agent, light-cure cement, bonding the veneers to the zirconia to close the screw channel. This is the immediate result taken by ring flash, and I was lucky to see my patient after 4 months. This is the retracted view taken by a softbox studio light. This is the right side, left side. This is the positive smile line we can create, upper and lower. Articulating paper 19 micron, well distribution of occlusion force. Also for the lower. and have a small video. This is show the difference between before and after treatment in distribution of occlusal force. So we start like in just only one contact by Shimister, and then we have nice distribution for contacts. Also for dynamic occlusion, this is the anterior guidance with the seclusion of posterior teeth. Canine guidance from both sides, and also it's very important to have smooth movement in all directions without any interference. This is the final smile, left and right side. And this is, it's like the impact of our restorations on the patient face. And this is the final slide. I leave you with like a summary for the positive effect we made on patients. And thank you.
Any questions?
شكرا جزيلا للمحاضرة هذه المحاضرة الرائعة. يتفضل السيد رئيس الجلسة لتقديم شهادة تقديرية للمحاضرة. مع الأستاذ المشرف الدكتور منهل.